Hello and welcome back to Chapter 3. We're talking about freestanding ambulatory care, and we're going to pick up with reimbursement. We're starting on page 96, and we're going to start with fee-for-service. Fee-for-service is the traditional method of payment in ambulatory care. In this system, the patient pays according to the type and amount of services provided. Usually when you go to a physician's office, there's going to be a visit fee. There's a basic fee for the visit, and then you have separate fees assigned on if you have a lab test like a urinalysis, or you have an x-ray of your wrist, or any other services provided beyond the basic visit. So let's say a child has strep throat and they get a shot. There's going to be a charge for that shot. In some facilities treating low-income patients, fee-for-service may be charged based on a sliding scale, and that means the amount's going to be determined by the patient's income. So if they have a low income, then the payment's going to be lower. If income's a little higher, then the payment may be a little higher. One of the traditional, or one of the biggest issues with fee-for-service is that payers think it offers an incentive to providers to provide more services, because the more services you provide under fee-for-service, the more money you're going to get paid. So if I start giving you tons of lab tests because I'm going to get paid for each of those lab tests, then I'm not using my services wisely. So a lot of times, we're trying to get away from the whole fee-for-service model. All right, dropping down to Medicare physician fee schedule. For physician reimbursement, Part B of Medicare now pays using the Medicare Physician Fee Schedule, which is based on the Resource-Based Relative Value Scale, the RBRVS. Medicare Part B includes physician payments and payment for services for limited licensed practitioners who treat only particular types of problems or parts of the body. So that's going to be your eye doctors, your foot doctors, and your chiropractors. Other services included are diagnostic tests other than clinical diagnostic lab tests, diagnostic and therapeutic radiology services, and physical and occupational therapy services. Non-physician caregivers, such as your nurse or your physician assistants, nurse practitioners, certified registered nurse anesthetists, certified nurse midwives, clinical psychologists, and clinical social workers are also paid at a rate tied to the RBRVS. Now, if services are provided to the patient by a nurse practitioner or by a physician assistant, and there is a physician on site, this is termed incident to services, and that definition is over in the margin over there. But these guys are fully reimbursed at the physician's rate provided by the fee schedule. So if a physician assistant or nurse practitioner treats a patient while there's a physician on site, then they get that full physician's rate fee. Now, locum tenens, these are primary care physicians and could be specialists, I guess, but they come in for just short amounts of time. Let's say you've got a doctor in your practice who's going to have knee surgery, a knee replacement, and they're going to be out of work for 6 weeks. Well, he may have a big caseload, and you may not be able to handle all that caseload, so you may bring in a locum. They're going to come in and they're going to work for 8 weeks while your partner is recovering. So they come in temporarily. Now, when a locum tenens comes in, the regular physician files the claim for the services provided by the locum tenens. So the locum tenens is not the one filing the payment. It's happening under the regular physician. All right, so dropping down to ambulatory surgery care center reimbursement. Freestanding ambulatory surgery centers are paid by Medicare based on a list of HCPCS and CPT codes for covered surgical procedures for ambulatory surgery centers, and it's updated annually. Medicare's ambulatory surgery center reimbursement system was revised in 2008 and provides that ASCs receive a percentage of the outpatient prospective payment system rates. Okay, so what's capitation? The RBRVS and ASC payments were efforts to prospectively set prices and to discourage excessive utilization of services. Capitation is a method of payment that carries this effort even further. Under capitation, caregivers received a fixed payment per month for anyone under their care enrolled in a given can't even talk, enrolled in a given healthcare plan. For this fixed amount of payment, all necessary health services must be provided. So, in the scenario I used earlier where I'm giving you all these different lab tests because I'm going to get paid for all these different lab tests, well, that's not how it works in capitation. I may only be getting paid enough money to cover 2 lab tests. So if I give you 4 lab tests, then I've lost money, because in capitation I'm getting paid a flat fee, no more, no less. And so I need to stay within the means of what I'm going to get paid, unless it's necessary, and then I would have to go outside of that. Sometimes you might use less to treat a patient, and so you're going to gain money there. Sometimes you may break even, and then sometimes you're going to use more services than you're actually getting paid for in this capitation method. But the incentive is to provide only care that's absolutely necessary to avoiding money. That's if you're getting paid on a capitation basis. All right, changing over to page 98, talking about the Medicaid Early and Periodic Screening, Diagnostic, and Treatment Service. The Early and Periodic Screening, Diagnostic, and Treatment Service is a program of Medicaid for children younger than 21. It ensures that these services are provided and paid for whether or not they are normally included under the state's Medicaid program. Screening services include history and physical, appropriate immunizations, health education, vision, hearing, and dental services. All right, so we've talked about our different methods of reimbursement. Let's talk about what resources are out there. Now, CMS offers a variety of manuals and materials that provide information about reimbursement under the Medicare and Medicaid programs. Program manuals provide the basic instructions for the 2 programs. Program transmittals are issued periodically to provide a revision for a special manual or specific manual. These manuals and transmittals must be reviewed to ensure that the facility is following the latest guideline. Claims for Medicare ambulatory care under Part B are filed with the Medicare Administrative Contractor, or MAC, Part B, in a given state or region. These Part B contractors publish local coverage determinations, these are your LCDs, which must be consistent with federal guidelines, but provide further guidance for providers in the area served by a specific contractor. Most coverage determinations are local. Medicare, however, also has developed national coverage determinations, these are your NCDs, that apply to all contractors and providers nationwide. LCDs and NCDs are important references for coders because they list diagnosis codes that indicate the medical necessity of certain procedures and services. So when you get over into your second semester of coding, where you're going to cover CPT, you'll learn a little bit more about your LCDs and NCDs. All right, so moving over to page 99, talking about coding and classification. We talked about ICD-10 in health records, and so most facilities use a method to code diagnosis and procedures. This process involves assigning a string of characters, it's a combination of numbers and or letters, to each of the diagnoses and procedures according to an established classification method. Coding is done in ambulatory care primarily to expedite the reimbursement process. Most third-party payers require codes for the diagnosis and procedures be submitted on claim forms. Electronic systems can more easily process codes rather than written descriptions of the patient's diagnosis and procedures. The main factor considered in choosing coding systems for ambulatory care is which systems are required by third-party payers. Most ambulatory care settings do not want to code with one system for reimbursement and another for classification purposes. The current clinical modification of International Classification of Disease, which is ICD-10, is the system used most often for coding diagnosis in ambulatory care. The disease classification for ICD is maintained by the National Center for Health Statistics of the U.S. government and is revised semi-annually. Then you have the Healthcare Common Procedural Coding System, which is our HCPCS, and it is used to code procedures and evaluation and management services in ambulatory care. 2 levels of codes make up the HCPCS system. Level 1 consists of CPT, Current Procedural Terminology, and these codes are developed by the American Medical Association. Dropping down at the bottom of that section, other coding systems occasionally are seen in ambulatory settings. The International Classification of Primary Care, or the ICPC, is a coding system developed by the World Organization of National Colleges, Academics, and Academic Associations of General Practitioners and Family Physicians. It includes chapters arranged by body systems with components that describe the reason why the patient is being seen for care at the primary care level. All right, dropping down to data and information flow. Most healthcare professionals or health information professionals are more familiar with the workflow of a hospital's HIM department. The work begins when the patient's discharged. Staffing requirements are often determined based on the number of discharges to be processed. But in ambulatory care, the visit is the driving force in determining the workflow and staffing requirements. The visit creates the need for the patient's record to be available so past care can be reviewed and the current treatment recorded. The workflow begins when an appointment is scheduled for the patient. Standard scheduling and block appointment methods are typical appointment scheduling patterns. In standard scheduling, patients are scheduled continuously throughout the day with appointment times at specific intervals. So you could have appointments set at every 15 minutes or so. This method sometimes results in wasted physician time when physician lengths are shorter than expected or when patients are no-shows. Standard scheduling time does not eliminate patient waiting time because some visits run longer than the time allotted, putting all subsequent visits behind schedule. The block appointment method helps to alleviate wasted physician time by scheduling multiple patients for the same time slot. In this method, patients are assigned to the same appointment time, so 9 o'clock for all morning appointments. Then patients are seen on a first-come, first-served basis. The disadvantage to the block appointment method is that the patient satisfaction suffers when some patients have to wait several hours to be seen by the physician. And then we have a modification of the standard and the block time schedules. This is when 2 patients are scheduled at the top of each hour and 2 patients at the half hour, then seeing the patients in the order in which they arrive. So you would have 2 patients scheduled at 9 a.m. and you would have 2 patients scheduled at 9:30 a.m. And you would see whichever patient came in first for their 9 o'clock appointment, then see the second 9 o'clock, and then you'd be ready to see your 9:30 patients. All right, switching over, we're going to skip over that section. So again, be sure to read these sections. Again, I'm covering the highlights. We're skipping over to page 103, and we're going to talk about record linkage to other sites. Many freestanding ambulatory care centers have multiple sites and must find a way to provide patient information among the various sites. This task is easiest with an electronic health record that can be accessed from all sites. In such a system, any of the locations can access the patient's information through the system. But in paper-based systems, the record can only be stored one site at a time. So again, we go back to the age-old thing. Only one person can have their hands on the paper at one time. If I come to one location and I was at a different location last time, then my record is at the other location. So facilities use a variety of ways to maintain the location or home base of the record. In some sites, the patient designates a home facility where he or she is usually seen, and the record is routinely kept at that location. Other facilities keep the record in the last site where the patient was seen. In either case, if a patient is seen at a site other than the record's home base, a method must be in place to have information available at another site when the patient is seen there. For scheduled visit, a courier is often used to transport the record to the site of the visit. For unscheduled visits, the pertinent parts of the record may be faxed to the other site from the home base. In either case, policies and procedures must be in place to ensure the safety of the record. All right, moving over to page 104, talking about computer systems. Ambulatory care centers often use computers to assist in the operation of the facility. A patient registration system or appointment system is often an important part of such a system for the HIM department. The patient's scheduled visit is entered into the computer, and a list of records needed for a particular day then can be generated automatically from the schedule. A patient registration or appointment system also is vital for keeping up with basic demographic information about the patient. In such a system, basic information, name, address, insurance, responsible party is collected when the patient is first seen. This information must be updated at each visit to maintain an accurate file. The registration system may provide a basic or a master patient index for the HIM department, including the patient's record number, which is needed to enable the department to locate the patient's record in a paper-based system. A financial system maintains information on services billed, determination of insurance coverage, payment received from patients and insurance companies, and collection efforts. Moving over to 105, electronic health records are used in some freestanding ambulatory care settings. Some physicians' offices and other ambulatory care settings are leading the way toward an electronic health record because the ambulatory record is less complex and easier to maintain electronically than is the hospital record. EHR modules can be integrated with the current practice management system. Other facilities still depend totally on the paper-based record. In most ambulatory care settings, the computer has been primarily used for administrative tasks. In 2013, 78% of office-based physicians used any type of electronic health record, and this was an increase from 18% in 2001. Some advantages of your EHRs extend beyond just having the information on the computer where it can be accessed by multiple users. One of these functions is decision support. In a decision support system, information about the patient's signs and symptoms, as well as lab and other diagnostic tests, may be used with an artificial intelligence system to help the physician in selecting a diagnosis. Automated online reminders also can be built into the system to remind physicians that patients need certain services such as immunizations for children, yearly mammograms, or routine monitoring. Dropping down, CMS has offered providers an incentive for adopting e-prescribing, which requires providers to submit electronic prescriptions via certified EHR technology. The incentives are being phased out as an ERX is now part of the meaningful use incentives. And then moving over to page 106, dropping down to where it starts talking about our patient portals. We mentioned this in health record or in law and ethics. Patient portal is one answer to confidentiality concerns regarding email and patient access to the health record. A patient portal is a secure online web link that gives patients access to personal health information. Patients can use the secure portals to carry out activities such as scheduling visits, visiting health information, viewing health information such as laboratory reports, and requesting medication refills. Stage 2, meaningful use of an EHR, requires that patients have electronic access to their health information. Implementing patient portals is becoming more common. Alright, and let's drop down to our data set. So we learned in health records that the Uniform Ambulatory Care Data Set is our data set for outpatients. And so in many settings, minimum data sets have been developed to provide guidance on the information that should be kept in patients' records. In ambulatory care, the Uniform Ambulatory Care Data Set, or the UACDS, has been introduced to serve that purpose. This data set includes the three main types of data: patient data, provider data, and encounter data. Patient data provides basic information about the patient. Provider data includes information about the provider, such as their unique provider identifier and location. And encounter data includes the date, reason for encounter, the services rendered, and the disposition. Alright, dropping down to that next section on 107, Quality Improvement and Utilization Management. A major use of health information in ambulatory care is the assessment of quality of care provided by the facility. The quality assessment and improvement process in ambulatory care follows the same methods used in other care settings. Problems or processes must be chosen for study, data must be collected to measure these processes, data must be assessed, and a method for improvement must be developed. The major difference in ambulatory care is that many factors affecting the quality of care are not within the sole control of the ambulatory facility. The patient's contact with the facility is usually brief, and the patient's outcome depends in large part on their compliance with the care plan developed. The patient's continuity of care may depend on factors in the patient's, not the facility's, control, such as missed appointments and consistent use of a primary care provider to coordinate care. Flipping over to 108, patient satisfaction is also an important part of the quality assessment process in ambulatory care because the patient's compliance may be closely tied to satisfaction with the care received. The ability to determine the quality of care within a facility is highly dependent on the quality of data collected within the health record. The Centers for Medicare and Medicaid Services have established a physician quality reporting system. PQRS is a reporting program that uses a combination of incentive payments and payment adjustments to promote reporting of quality information by eligible providers. Under this program, physicians, podiatrists, physician assistants, nurse practitioners, and physical therapists reporting on a list of quality measures defined each year by CMS. The measures to be collected may vary from year to year, and each year's requirements are published in the Federal Register. All right, dropping down to utilization management. Utilization management is the process of determining the appropriateness of services and treatment provided to the patient based on the patient's needs. In the hospital setting, this process often focuses on whether or not the patient requires hospitalization. In ambulatory care, utilization management is more likely to focus on the necessity of the service, such as a referral to a specialist, or the use of an expensive procedure, such as an MRI, or the appropriateness of referrals for hospitalization. Emphasis should be on services that are either high volume or high cost, because not all services can be examined. Standards or criteria that are credible and specific should be established. So there's two main approaches to utilization management. One is prospective review pre-certification, in which the service is examined before it's provided. Data is collected, usually by a nurse, from the patient and the physician. The facts of the individual case are compared to the appropriateness criteria. If the standards are met, the nurse can usually approve the service. If the standards are not met, a physician advisor may be asked to review the case and make a determination. The second major approach is retrospective review. In this methodology, care is looked at after it's given. Usually a sample of cases is selected. Data are collected from medical records and the information from the record is compared to the appropriateness standards. Feedback then is given to the appropriate caregiver regarding inappropriate care provided. All right, so we're going to skip over to page 111 and talk about the role of the health information manager in ambulatory care. The role of the HIM professional in freestanding ambulatory care often includes providing expertise in the areas of information management, regulatory compliance, electronic information systems, and administrative functions. In a paper-based ambulatory care setting, the primary role of the HIM department is chart location and control, making information management and supervision of personnel the main functions of the HIM professional in this scenario. And the role of the health information manager has been affected by the move to the EHR in freestanding ambulatory care. As facilities decide to implement EHRs, health information managers are involved in implementing these new systems and may serve as project managers. In smaller ambulatory care settings, HIM professionals often undertake roles outside of those usually identified with health information management. In some settings, for example, HIM professionals have duties in areas such as purchasing or patient registration. Some HIM professionals have expanded their knowledge of the ambulatory setting and now utilize their management and administrative skills to become medical group managers. Because the HIM field has not been as well known in ambulatory care as it has been in the hospital, HIM professionals in these settings also serve as marketers for their skills and demonstrate flexibility to assume a variety of responsibilities. So again, be sure to read the whole chapter, cover all the content, and happy reading.